When you think about an emergency scene, what comes to mind? Probably chaos, right? For a first responder, the very first job isn't medical. It's to cut right through all that noise. And they do it with a methodical assessment, a step-by-step process that's designed to bring order to chaos and fix life-threatening problems in just minutes. So let's break down exactly how they pull it off. Okay, so the clock starts ticking the very second an incident happens. You've probably heard of the golden hour, that critical window to get a patient from the point of injury to a hospital. But what's even crazier is what's inside that hour, the platinum 10 minutes. That's all the time they have on scene to assess the patient, figure out what's wrong, and get them ready for transport. Literally everything hinges on what they can do in those first few moments. So, put yourself in their boots for a second. You're the first one to arrive, there are lights, sounds, people yelling. It's a total sensory overload. How in the world do you focus? Where do you even start? Well, this is exactly why having a system is so absolutely critical. Now, you might be surprised to hear that the process doesn't even start with the patient. Nope, it begins the moment a responder pulls up, with something called the scene size up. The number one rule, the absolute top priority, is simple. You can't help anybody if you get hurt yourself. So before anything else, they are scanning the entire scene for dangers. We're talking down power lines, shaky buildings, even potential violence. Their safety comes first, always. And they're running through this mental checklist in just a few seconds. Okay, is the scene safe? Is this a medical call or did something cause this injury? Am I gloved up? How many patients do I have? Do I need to call for backup like the fire department or another ambulance? It's just this rapid-fire series of decisions that has to happen before they even step out of the vehicle. All right, once the scene is secure, then the hands-on work begins, and this is where things get really fast. It's called the primary assessment, and it's all about finding and fixing anything that could kill the patient in the next few minutes. And get this, the whole thing takes only 60 to 90 seconds, a minute and a half. The goal isn't to figure out exactly what's wrong, like a full diagnosis. No. The goal is to spot and immediately start treating things like a blocked airway, massive bleeding, or if their heart has stopped. It's all about stopping the clock on the most immediate threats. The order they do things in is so important here. For most patients, it's the classic ABC: airway, breathing, circulation. But if they see catastrophic bleeding or the patient is in cardiac arrest, the whole thing flips to CAB. Circulation comes first. And why is that? Well, think about it. It doesn't matter if you can breathe if you don't have any blood to carry that oxygen around your body. So stopping the bleed or getting the heart pumping again becomes priority number one. So here's what that looks like. For airway, the quickest check is just, can you talk to me? If they can talk or cry, their airway's open. For breathing, they're looking to see if it's too fast, too slow, or if they're struggling. And for circulation, they're feeling for a pulse and doing a super quick scan of the body, looking for any big bleeds that need to be stopped right now. And here's a really cool, simple trick they use to check circulation. It's called a capillary refill test. All you do is press on a fingernail until it turns white, and then you let go. The color should pop right back in under 2 seconds. If it's slower than that, it could be a sign of poor circulation. It's just a fast, low-tech, but super effective tool. While all of this is happening, they're also checking the patient's level of consciousness. They use the AVPU scale. Are they A, awake and alert? V, not awake but they respond when you talk to them? P, they only respond to a painful stimulus, like a pinch? Or are they U, completely unresponsive? It's a really quick way to get a baseline for their brain function. Okay, so once the immediate, life-threatening stuff is under control, it's time to put on the detective hat. This next part is called history taking, and it's all about gathering clues to figure out what's really going on. They use a great little mnemonic called SAMPLE to remember what to ask. S is for signs and symptoms. A for allergies. M for medications. P for pertinent past history. L for last meal or drink. And E for the events leading up to the call. Every single answer is another piece of the puzzle. And if there's a specific complaint, like say chest pain, they'll dig even deeper with another mnemonic, OPQRT. When did the pain start? What makes it better or worse? Can you describe the pain? Is it sharp, dull, pressure? Does it travel anywhere, like down your arm? All these questions help paint a really clear picture for the doctors at the hospital. But, this whole thing isn't just a technical checklist. Responders are dealing with people who are scared, in pain, and at their absolute most vulnerable. Sometimes they're even hostile. Being calm and reassuring is just as important as any medical skill. It's all about building trust in a moment of pure crisis. And that empathy really shines when they have to overcome communication barriers. If a patient is hearing impaired, that means speaking slowly, facing them so they can read your lips, or just using a good old pencil and paper. And here's a really clever trick. They can have the patient put the earpieces of a stethoscope in their own ears, and the responder can speak into the bell. It works like a simple amplifier. For a patient who is visually impaired, it's all about verbal cues. Announcing who you are, explaining every single thing you're about to do before you do it, and being really careful to put things back exactly where you found them. It's all about helping the patient maintain their sense of security and control when everything feels out of control. So, after the immediate threats are handled and the patient is relatively stable, if time allows, the responder moves on to the secondary assessment to get an even more complete picture. This is a much more detailed, systematic, head-to-toe physical exam. The goal here is to find the stuff that wasn't immediately life-threatening, but is still really important. A broken bone might not kill you right away, so it could be missed in that first 60-second scan. This is where they'll find it. And this assessment uses 3 main techniques. Inspection, which is just a fancy word for looking for swelling, bruises, anything out of the ordinary. Then there's palpation, which means touching or feeling for tenderness or deformities. And finally, auscultation, which is listening to body sounds, usually with a stethoscope, like checking lung sounds. But here's the thing. The job is never really done. Patient assessment isn't a one-and-done kind of deal. It's a continuous loop, and it's called reassessment. If a patient is unstable, meaning their condition is serious or could change at any moment, this entire process of checking their vitals and running through that primary assessment gets repeated every 5 minutes. Now, if the patient is stable, that reassessment happens every 15 minutes. And this constant checking is so critical because a patient who seems totally fine 1 minute can take a turn for the worse in a heartbeat. That vigilance is what saves lives. So this whole structured process, from the scene size up all the way to constant reassessment, is this amazing framework for turning absolute chaos into focused care. It makes sure that nothing critical gets missed when the pressure is on. But it also makes you wonder, right? Beyond all the checklists and mnemonics, how much of a first responder's success comes down to just pure human intuition, that gut feeling in the heat of the moment that tells them something just isn't right.